neuromuscular. I'm talking about any doubts regarding the reversal. Reversal we are going to discuss today. Any doubts regarding monitoring? Any doubts regarding the anatomy, physiology, pharmacology of neuromuscular blocking agents?
Maybe at the end of today's class, we might have.
Okay. Anyway, now I was mentioning, Dr. Mahal, also your exams are fast approaching another 4 or 5 months. So you have to be very serious. You have to really start studying from, at least you already started. You should be more serious in studying, revise things so that, you'll remember better. Okay, now coming to the today's topic, that is antagonism of neuromuscular blockade. So one question to Mona is, why should we antagonize or why should we reverse neuromuscular blockade?
There will be inadequate blockade, like we are blocking the all the muscles. I mean,
No, you are producing a neuromuscular blockade, you are producing paralysis of the muscles
paralysis of the muscle.
for the sake of surgery, isn't it? So that the patient should not move, one. And the second thing is there should be good relaxation for the surgeon. The third is for you to intubate the patient also. You require good relaxation. Otherwise, you can intubate with patient breathing spontaneously with inhalation anesthetic agents also. And nowadays, even rapid sequence induction has been done, proposed, of course, without neuromuscular blockade, especially use of high dose remifentanil. So that I'll be discussing. Next topic for discussion will be opioids. So there I'll be discussing about rapid sequence induction and intubation using high dose remifentanil. So, but one problem when you don't use neuromuscular blocking agents for intubation is there is going to be some amount of damage to the probably the mucosa of the larynx, because you are forcing your endotracheal tube through the unparalyzed larynx, isn't it? When you are not using neuromuscular blockade and you are not paralyzing the adductors of the larynx. So there is one of the problems is post-operative sore throat is one of the problems when you don't use neuromuscular blockade. So neuromuscular blockade is always used for intubation. One second thing is for you to see that the patient remains still throughout the surgery. Of course, depth of anesthesia is very important to keep the patient still, but neuromuscular blockade also helps, and especially those surgeries wherein you do not want any kind of movement of the patient, like neurosurgeries, especially the aneurysmal surgeries of the brain, then retinal surgeries, ear surgeries, plastic surgeries, cosmetic surgeries, where absolute stillness of the patient is required, you definitely required to use, and it has to be a deep or intense neuromuscular blockade has to be there. And for abdominal surgeries, the surgeon requires very good relaxation. And again, laparoscopic surgeries, you don't want much of intra-abdominal pressure. For all these things, neuromuscular blockade is essential. Now, once the neuromuscular blockade you have created by using neuromuscular blocking agents, now my question to you, I just now asked, is why should you reverse this neuromuscular blockade? So because, one thing is, if you just leave the patient to come out of the blockade or the paralysis introduced by these neuromuscular blocking agents, he'll come out of the paralysis. You need not have to reverse, because it all depends on the movement of these particles of the neuromuscular blocking agents from the motor end plate, where they are producing blocking of the nicotinic receptors. They move towards the blood gradually after some time, and from the blood to the liver or kidney, where they require to be metabolized, or with benzyl isoquinoline group of drugs. Once they move into the, even otherwise also, because of Hoffman's elimination, and because once they move into the plasma, again, ester-hydrolysis will occur, and they get eliminated, isn't it? So once the number of molecules of non-depolarizing muscle relaxants come down in the neuromuscular junction, the activity of the acetylcholine will increase and the patient will regain the motor power. So once these things are there, so why are you required to reverse?
We don't want any residual blockade. There might be because of long-acting non-depolarizing muscle relaxant.
No, but we are not using long-acting non-depolarizer, isn't it? Nowadays, we are using intermediate-acting neuromuscular blockade.
Sir, in case of elderly,
No,
there
but, one thing you should realize, Mona and Varshini, is they have done studies on volunteers wherein they have given vecuronium, that is an intermediate acting non-depolarizing muscle relaxant, aminosteroid, and rocuronium for patients, the volunteers. And they have studied without reversing after about 2 to 3 hours. Even after 3 hours, the trainer 4 was less than 0.9 in many of these individuals. That means they continue to have some amount of the blockade, some amount of weakness because of the residual effects of these neuromuscular blocking agents. So it may take a long time for all the neuromuscular blocking agents to leave neuromuscular junction and the patient to get back his motor power. So that is the reason you cannot just, keep on ventilating the patient in the OT, isn't it? How long you can ventilate, waiting for the drug to get metabolized and eliminated from the body. So it will take a long time. So in order to prevent that, you would like to antagonize the effects of these, neuromuscular blocking agents. But even after antagonizing, as you said, there is always a possibility of residual neuromuscular block. Now, Varshini, can you just tell what do you mean by residual neuromuscular? How do you know that the patient has got residual neuromuscular blockade or not?
Sir, we can do qualitative and quantitative analysis with the neuromuscular monitors, sir.
Yeah, it is mainly by the quantitative measurement
Quantitative measurement.
of the neuromuscular, blockade, isn't it? So by using a quantitative monitor, it's only by using a quantitative monitor only you can know whether there is still persisting residual neuromuscular blockade is there or not. Otherwise, you'll not be able to make out. So with a quantitative monitor, how do you know that the patient has got residual neuromuscular block? What makes you think that there is a residual neuromuscular block?
if there's a airway obstruction or a
No.
patient.
Don't get confused. No, you should listen to, in the exam also, it is very important to listen to the question. I'm asking by using quantitative monitoring, how do you know that there is a residual neuromuscular block? You're using a quantitative monitor.
With an acceleromeograph.
No. You're using a quantitative monitor. You're using trainer 4 ratio. Isn't it? There are two things, trainer 4 count and trainer 4 ratio. And if you are using trainer 4 count, all count will be there. All 4 trainer 4 responses will be there for the trainer 4 stimulus. So now that means there is a trainer 4 ratio is there. The ratio is between the amplitude of the fourth response to the first response. That is called as trainer 4 ratio. And you look for the trainer 4 ratio. When do you say that the patient has been completely reversed, looking at the trainer 4 ratio? And when do you think that the patient has residual neuromuscular block, looking at the trainer 4 ratio?
So when the TOF is more than 0.9,
Yes, very good.
the patient is completely out of the block.
Yeah, completely reverse. When it is 0.9 to 1, you can say. 1 is with acceleromyography.
Yes.
0.9 with others, because acceleromyography will just, give slightly higher reading when compared to the others. So that even 0.9 of acceleromyography, maybe 0.8 of mechanomyography or even electromyography or kinemyography. So if you are using acceleromyography, it has to be 1 ideally. Or you go for, last week I was discussing with you normalization.
Yes, sir.
With acceleromyography, you have to do it. Okay. When it is more than 0.9 with others and 1 with acceleromyography, you know that the patient has been completely reversed, isn't it? So if it is less than 0.9,
So
There is-
anything below 0.9 is residual
Yeah,
blockage.
that is what you have to say. Less than 0.9, above 0.4, because why I'm telling above 0.4 with a qualitative monitoring, just looking at the response, you're not quantifying it. It's only a quality. You're just seeing how many responses are there, whether it's, fading is there or not. So you cannot realize that the fade may be still there, but your eyes will not be able to appreciate the fade once it is more than 0.4. And even with double burst stimulation, anything above 0.6, you will not be able to find out the fade. So that is why qualitative monitoring, you will not know whether there is a residual neuromuscular blockade is still there or not. It is only with a quantitative monitoring, you can definitely say whether the patient has completely reversed or still there is some amount of residual neuromuscular blockade is there. Now, Mona, if you think that there is a complete reversal by using your quantitative monitoring, do you think that, and what will be the number of receptors that are blocked when you think that the patient has completely come out? Still, how many receptors could be blocked? Last week I had discussed this with you because
alpha subunits.
no. Percentage of receptors
25.
still could be blocked because there is always a margin of safety in the neuromuscular junction.
Yes.
How many percentage of receptors still could be blocked by non-depolarizing muscle relaxants, but the patient will have complete motor power. And if you do a quantitative monitoring, it will be 1 with accelerometry and above 0.9 with other type of monitors. How much of percentage of receptors still could be blocked?
25% of
Could be relieved or could be blocked?
Could be
could be
blocked.
blocked.
It is only that 25% of the receptors are not blocked.
Okay.
That is the margin of safety. Even 70% of the receptors are blocked, the patients will have full power. 30% of the receptors active is enough for your quantitative monitor to show 1 as the train of 4 ratio. And the patient will not have any kind of, residual neuromuscular palsy like. Even those 65 to 70% of the receptors may still be blocked by neuromuscular blocking agents. And why this is very important to know. Why this particular thing about the margin of safety is very important for you to know.
So
That
because
you shift the patient to the post-operative ward, you have done a quantitative monitoring using your quantitative monitor of train of 4 ratio. Ratio is 1, and you think that everything is fine, you are shifting the patient to the post-operative ward, not realizing that still there can be 65 to 70% of the receptors could be blocked. What is the consequence of this?
Inadequate reversal.
No, it is not inadequate reversal, it is a complete reversal. Because 30% of the receptors, if they are free, patient will not have any kind of weakness or residual neuromuscular blockade. That is, you see, even let us say that still 70% of the receptors are blocked. So patient you shift the patient to the post-operative ward, everything is fine. There suddenly, the surgeon wants the patient to be given an aminoglycoside antibiotic. Once the surgeon asks, the nursing attendant gives, so what will happen is suddenly the acetylcholine level will come down because aminoglycosides will block the calcium channels. Acetylcholine release suddenly will be decreased. Now what will happen is this 70% of the motor blockade that is there will take an upper hand. Patient can go for what is called as recurization. It's
Yes.
called as a recurite. So again, the patient can develop weakness. So that is why it is very important to know about this effect of neuromuscular blocking agents at the neuromuscular junction. Still, you are not sure that 70% of the receptors are still maybe under the influence of the neuromuscular blocking agents. So that is one thing you should always realize. Now, what is the incidence of residual neuromuscular blockade? That is, when you are doing a quantitative monitoring and the blockade is, or Trainer-4 ratio is between 0.4 to 0.9, we call it as a residual neuromuscular blockade. And what may be the incidence of this residual neuromuscular blockade if you are not using a quantitative monitoring? Many times you are not using, isn't it?
Yes, sir.
You just shift the patient and you think that the patient has completely come out. But what could be the incidence of residual neuromuscular blockade in the patients?
Sir, about
20%.
You are guessing. What the studies, a lot of studies have been done. And many of the studies, they have just checked they have not done any checking during the intraoperative period. They have reversed the patient. And after reversing the patient, thinking that the patients have come out of completely reversed with neuromuscular blockers, they have been shifted. And the study was started in the postoperative period. So they have used a quantitative monitor and checked for how many patients have still residual neuromuscular blockade. It is the incidence is 40 to 60%. Can you imagine? That means if you shift 100 patients, still 40 to 60 patients can still have residual neuromuscular palsy. And this is a very high number. That is why they are giving a lot of importance to the quantitative monitoring of the neuromuscular junction intraoperatively and immediate postoperative. That is why it has been a minimum mandatory monitor in majority of the European countries, and in US also they have started this, and in Australia and New Zealand. Now, if you are using a neuromuscular blocking agent, you have to use neuromuscular monitoring, that to a quantitative monitoring, because that is the high incidence of residual neuromuscular block. Okay, if there is residual neuromuscular block, what are the consequences of residual neuromuscular block? Can you just tell what all the problems this residual neuromuscular block can produce?
airway obstruction.
The airway obstruction, okay, why airway obstruction occurs?
So, tongue.
The diaphragm muscle is still paralyzed. So
Diaphragm are paralyzed or diaphragm are highly resistant for neuromuscular blocking agents. They are the first one to recover.
they're the
First one
first
to
one to recover.
If they are first one to
Yeah.
recover,
There
patient
is
will be
larynx-
breathing well. That's how you are shifting. Patient is breathing well, his tidal volume is good. So you think that the patient has come out, you have taken out the endotracheal tube, you have shifted. But there can be airway collapse. Why there can be airway collapse? Already we have discussed this many times.
The laryngeal muscles are still
Hypoxia.
Laryngeal muscles are resistant. Adductor muscles in the larynx are resistant. They are as resistant to neuromuscular blocking agents like diaphragm. 3 muscles I told you. Diaphragm, laryngeal adductors, corrugated
corrugate
superciliary,
or superciliary.
then abdominal muscles. They are highly resistant. So patient would have come out of, these muscles would have come out of the blocking agents. But still the patient can develop airway obstruction. Why?
Reduced ventilatory drive.
Drive.
That is later, isn't it? Why? You said airway collapse. That means the pharyngeal collapse is occurring, isn't it?
Yes, sir.
Why pharyngeal collapse is occurring? Because when you take an inspiration, you are creating a very high negative pressure inside the airway, isn't it?
Yes, sir.
Normally. And when you are creating such a high negative pressure, actually the upper airway muscles, they have to produce dilatation of the pharynx. Otherwise, there will be airway collapse. They have to resist this negative pressure normally. Otherwise, there will be collapse of the airway, isn't it? It is the genioglossus muscle, the genioglossus muscle, which is very important for the supply of, the tongue. The genioglossus muscle, along with other pharyngeal dilators, will maintain the patency of the pharynx when you are taking an inspiration and creating a negative pressure. So, but what happens is, you know that these pharyngeal muscles, dilator muscles, and the genioglossus muscle, which are called as the upper airway muscles, are highly sensitive to the effect of neuromuscular blocking agents. And though the diaphragm is, has come out, the laryngeal adductors have come out, but still these muscles may still be under the influence of neuromuscular blocking agents. Their tone is reduced. They have not completely recovered from the neuromuscular blocking agents. So what will happen is this genioglossus, along with the dilators of the pharynx, they may not be able to maintain the patency of the upper airway whenever the patient tries to take a breath and creates a negative pressure. They collapse. And once they collapse, there is an upper airway obstruction. And whenever there is an upper airway obstruction, what will happen is the patient is going to have hypoxia. Isn't he? He is not able to breathe well. So, Varshini, you are telling about hypoxic ventilatory response. What is this hypoxic ventilator response and what happens to hypoxic ventilator response if there is a residual neuromuscular blockade?
It's the ventilatory response is reduced, sir.
Now, from where actually this response will occur actually, whenever hypoxia is there?
The respiratory centers.
Is it a central respiratory center or peripheral respiratory center?
Central.
Central is only responding to carbon dioxide,
Okay.
isn't it? You have two kinds of hydrogen ion chemoreceptors which get activated and then respond to and produce ventilation. One is the central hydrogen ion chemoreceptors, which are present in the medulla in the respiratory center. And these are the ones which get activated by carbon dioxide. Any increase in carbon dioxide, they get activated. Hypercapnia or hypercarbia will produce stimulation of these central hydrogen ion chemoreceptors, and there is increased response, increase in the ventilatory response. But for hypoxia, it is the peripheral hydrogen ion chemoreceptors that are present in the carotid body. The carotid body is present in between at the junction of the common carotid into the external and internal carotid. There exactly is the carotid body is there, and this carotid body gets a maximum amount of blood supply. Per gram it gets 2000 ml per minute of blood supply. So that means it is highly sensitive. And whenever there is hypoxia, the hydrogen ion chemoreceptors in the peripheral hydrogen ion chemoreceptors that are present in the carotid body, they get activated, they improve the ventilatory response. They produce, increase in respiratory rate and tidal volume. And neuromuscular blocking agents will block these hydrogen ion chemoreceptors in the carotid body. And it is extremely sensitive to the effect of neuromuscular blocking agents. And whenever there is residual neuromuscular blockade is there, this peripheral hydrogen ion chemoreceptors in the carotid body will be, inhibited. So even though patient is having hypoxia, there may not be ventilator response, increased ventilator response. So a patient will continue to go into respiratory obstruction, continued hypoxia, and the consequences of postoperative hypoxemia, isn't it? So this is one of the problems with the residual neuromuscular palsy. Okay. What happens to the upper esophageal sphincter tone whenever the residual neuromuscular palsy is there?
It's reduced, sir.
Yeah, reduced upper esophageal sphincter tone, because these also muscles are extremely sensitive to the effect of neuromuscular blocking agents. So if the upper airway upper esophageal sphincter tone is reduced, what is the problem?
Difficulty in swallowing.
Yeah, one is difficulty to swallow because incoordinated activity of this, upper esophageal sphincter muscles are there. One is difficulty for the patient to swallow. Okay, very good. Then
Of aspiration.
aspiration risk, very important. There is always a risk of aspiration in the postoperative period if there is a residual neuromuscular palsy. And what is the effect of aspiration? So what if aspiration occurs?
Consolidation,
It is
pneumonitis. Pneumonitis.
Pneumonia, post-op pneumonia, POP, it's abbreviated as post-operative pneumonia, post-operative, pulmonary complications. And, the patient requires a prolonged hospital stay. Even mortality can occur for these patients. So unnecessary extended period of hospitalization and including mortality can occur just because of residual neuromuscular palsy, isn't it? So the problem again is because of upper esophageal sphincter tone is reduced, so there's a possibility of aspiration. And what are the other symptoms? These patient will be able to speak well.
Slurring
Slurred
of speech.
A patient will not be able to speak well. And, there is always a possibility of, difficulty to swallow. Suppose you give some, thinking that everything is fine, you start giving some fluids for the patient to, take, or many times, it is very common with ambulatory surgeries. You give something to eat for the patient, thinking that everything is fine. Now, this can go directly into the trachea and the patient may get aspirated. So that is another problem. As far as his vision is concerned, what is the problem with vision?
Blurred vision.
Blurring of vision.
You
Diplopia.
can have diplopia, you'll have difficulty to, see things also. And you will have a generalized sort of weakness because even the peripheral muscles will be very weak. If you ask him to lift his hand, he may not be able to lift his hand also. Peripheral weakness also can be there. Okay, so these are all the problems associated with residual neuromuscular palsy. Now you tell me what are the factors which can influence or major factors for production or for this residual neuromuscular palsy to occur. What are the patient factors? What are the intraoperative factors? What are the factors because of the antagonism you use? And what are the factors because of the monitoring? What are the post-operative factors? So we'll come to one by one. What are the patient factors which can make them prone for residual neuromuscular palsy?
Elderly patients, they're more sensitive to non-depolarizing muscle relaxants.
Very good. So elderly patients, age is one of the very important thing.
Age.
Can you just tell why elderly patients are highly sensitive to neuromuscular blocking agents?
Because there's a reduced number of
acetylcholine in
receptors at the junction.
junction
Yeah,
and
one is the reduced number of receptors. Okay, what are the other anatomical problems?
sir, the cleft is shallow, sir. The
Yeah, very good. So the secondary clefts, primary clefts are shallow. That is another thing. What happens to the distance of or the length of the synapse?
Reduced synaptic efficiency.
Increased. The distance between the presynaptic nerve ending and the motor end plate is increased. So that, it takes longer time for acetylcholine molecules to reach the receptors. That is another problem. What is another problem as far as the presynaptic nerve ending is concerned? What about the release of acetylcholine? Number of acetylcholine molecules that is released.
Reduced.
decreased.
Again, the number of acetylcholine molecules that are released are also reduced. And number of the vesicles containing the acetylcholine molecules are also less in elderly. And the other problem in elderly, metabolism of these drugs, especially the liver and kidney,
Liver functions.
isn't it? So the liver functions, everything is what we call it as homeostenosis in elderly. Homeostenosis, that means functions of all the organs of the body is reduced, including the liver and kidney, where these neuromuscular blocking agents are metabolized and excreted. So naturally, because they are not getting metabolized, not getting excreted, they'll have a more longer duration in the body because of the pharmacokinetic problems. So because of all these, so elderly patients are highly prone for residual neuromuscular blockade. So I have to be extremely careful in these patients, isn't it? Okay. So then what about male gender and female gender? Which gender is more prone?
Male are more.
It is the females who are more prone. Females are more prone again because the less number of receptors, smaller muscles come, they are more prone. Okay. So then what are the patient's pre-existing medical conditions which can make them prone to have residual neuromuscular palsy?
So muscular dystrophy, myopathies,
Very good.
Yeah, great.
myasthenia gravis.
Yeah, any kind of muscle
Yeah.
weakness already present in the patient, definitely. And how about patients with morbid obesity?
Obese patient also more.
Because, especially patients with OSA, obstructive sleep apnea, slightest of neuromuscular palsy in these patients, they are highly prone for the residual neuromuscular palsy. As such, they'll have an collapse of the upper airway, very common with obstructive sleep apnea patients. So they are again more prone for, residual neuromuscular palsy. Okay, if the patient is on certain medications, again, last time I had asked you this.
Aminoglycosides.
Pardon?
Aminoglycosides.
Yeah, patients
Calcium
on
channel blocker.
antibiotics, aminoglycoside antibiotics, right? Then
Calcium channel blocker.
calcium channel
Anti-arrhythmic.
blockers may not produce because they are slow calcium channel blockers. And here in the neuromuscular junction, it is a fast calcium channel. That is a P channels. They are active.
Lithium.
Lithium, yes, very good. So if the
Like
if you are on lithium carbonate, again, it can, one of the drugs that can produce. Again, patients on diuretics, and which can produce, a lot of electrolyte disturbances, especially potassium. Hypokalemia, the patient is already having hypokalemia, and that can produce because of the diuretics. And magnesium, if the patient is on magnesium sulfate, like, pre-eclamptic mothers, or many times nowadays, magnesium sulfate is being used as a pre-induction drug to suppress the intubation response. And that can again, prolong the duration of action of non-depolarizing muscle relaxants. And it can be one of the drugs which can produce residual neuromuscular palsy. Okay, what are the intraoperative factors which can make the patient to prone for residual neuromuscular palsy?
Inhalation agents.
Yes,
CO.
very good. So it all depends on whether patient is on TIVA or patient is on regular, general anesthesia using inhalation anesthetic agents. Why inhalation anesthetic agents, if you are using intraoperatively, can make the patient to be more prone for residual neuromuscular palsy?
It increases the effect of mus
Good. Yes.
polarizing agents.
Pardon?
Non-polarizing agents. It increases the effect of non-depolarizing agents.
Yeah, because they themselves can produce decrease in the tone of the muscles, isn't it? By their central effect on the brain, central neuromuscular relaxation they produce. They have a presynaptic effect by reducing the acetylcholine release by blocking the calcium channels. And they also block the open, the nicotinic receptors. Physically, the molecules will block. And inside, again, the muscle cell, they prevent the release of calcium. And calcium release is very important for muscle contraction, isn't it? Because calcium has to bind to troponin to release actin filaments so that contraction can occur. So because at various levels, inhalation anesthetic agents can produce the, decrease in the neuromuscular power or the muscle tone. That's why they are very important as far as producing residual neuromuscular palsy. So that is okay. So intraoperatively, one is type of anesthesia you are using, whether TIVA. TIVA patients will come out early, and the chance of residual neuromuscular palsy is much less with when you use total intravenous anesthesia when compared to inhalation anesthesia. Okay. Is it anything to do with the type of neuromuscular blocker you use?
Yes, long-acting pancuronium.
Yeah, correct. When you use long-acting neuromuscular blocker like pancuronium or pipecuronium, because they are cumulative, they are highly cumulative, they'll be still there in the tissues. So you think that you have reversed the patient, but from the tissues, they enter back into the plasma. From the plasma, again, they'll go to the neuromuscular junction. And still there can be 60 to 70% of blockade may still be there. That's what I already told you. Another 5% blockade, again, trainer 4 will come down from 1 to again 0.6 or 0.7. So that is why long-acting neuromuscular agents and this recurrization, this residual neuromuscular palsy, all these things were very common when we were using long-acting non-depolarizing muscle relaxant. So type of muscle relaxant that you use is very important. And type of monitoring, does it also help in knowing whether patient has residual neuromuscular palsy or not? For example, you are using a qualitative monitoring, or you are not using any monitor at all. That also can have an effect,
Yes, sir.
isn't it? Then you will not be knowing whether the patient, when you are shifting, isn't it? So that is another very important thing. If you are using a quantitative monitor, you'll know exactly whether the patient has come out or not, isn't it? What is the trainer 4 ratio? And the last dose that you have given, does it matter? Last dose of neuromuscular blocking agent, and then you are going to reverse. Does it matter?
Yes, sir.
Yes, sir.
How it matters? Suppose you have given 5 minutes before, surgeon wanted relaxation of the abdomen, and patient is coming out, patient is moving. And he asks you, hey, patient is moving, you gave some relax. How many times you have given? Many times you must have given one more dose, isn't it? So given a dose, now the surgeon says that he is finished. Now after 5 minutes, you want to give the reversal.
The concentration of the drug is high in the neuromuscular junction, so now we cannot reverse the patient.
So again, that can be one of the problems, and that can definitely produce the residual neuromuscular block. Okay, and does it have anything to do with the depth of block? Residual neuromuscular block and depth of block during which you are trying to reverse. How do you, again, one more question. Last time I had asked you, how do you classify the depth of block? What are the different types of blockade?
Sir, trainer 4.
Now, how do you classify this block?
And
Okay, I'll tell you again, because last time so many questions I had asked regarding this. One is a complete block or an intense block.
Intense block, deep,
deep
Deep
mod,
block,
moderate,
moderate block, correct?
shallow,
Shallow block,
minimal and fully recovered.
minimal block, and complete recovery. These are 6 different types of block. And intense block or complete block is when there is no trainer 4, there is no trainer 4 count, there is
no
no tetanic response, there is no post-tetanic count. PTC 0, tetanic response is 0, trainer 4 is 0, trainer 4 count is 0. That you call it as the intense block or deep block. Whereas, intense block or complete block. Deep block is all are 0 except PTC. PTC
Post-tetanic
is just
will be
about 1.
1.
PTC is about 1. Moderate block, tetanic response is there. PTC will be more than 8. And your trainer 4 count will be 2 or 1 or 2. That you call it as moderate block. Then shallow block. What is shallow block?
trainer 4 count will be 4.
Yes, very good.
Ratio will be less than
Less than
0.4.
0.4.
Yes, very good. So less than 0.4, trainer 4. So minimal block.
Top
Train of 4. Train of 4 will be 4.
Ratio.
Top is 0.4 to 0.9.
Yeah, that is the minimal block, and patient, complete recovery is above 0.9. That is what is very important. So can I reverse the patient using my regular anticholinergics when the patient is having deep block or intense block?
No, sir.
No,
May
sir.
be reversed.
No, sir.
No, it will not be reversed, isn't it? So that is another, we'll come to that, why it will not be reversed and all later when you are going to reverse. So that is another factor which can influence the whether the patient can have, suppose if you give regular anticholinesterase reversal, when the patient is having a complete block or an intense block or deep block or even moderate block, so the residual block will be, chances of patient developing residual block will be very high, isn't it? So is it anything to do with the reversal agent you use and its dosage? Suppose I use Sugammadex and I use anticholinesterase. The patient, you have used aminosteroid like vecuronium or rocuronium. At the end of surgery, I would like to use Sugammadex. Residual neuromuscular block will be high or will be low?
Depending upon the dosage of the drug.
No, I have given the right dose of Sugammadex.
If the
And,
concentration,
I have also given the right dose of anticholinesterase, which may prevent residual neuromuscular block, which may not be able to completely prevent residual neuromuscular block. So it is always Sugammadex definitely will prevent residual neuromuscular block. Its method of reversal is completely different when compared to the anticholinesterases. So that is another very important thing. And another thing is, already we discussed the type of monitoring of the neuromuscular junction. Qualitative monitoring, still there will be chances of residual neuromuscular block, which you will not be knowing, but quantitative monitoring definitely will be knowing. What about the post-op factors which can influence residual neuromuscular blockade? Post-op factors.
hypothermia,
Very good. So hypothermia will again, patient can develop residual neuromuscular block if the patient has hypothermia. So especially 1 or 2 degrees decrease of the body temperature can again, make the neuromuscular junction very sensitive for these agents. And there can be, sudden increase in the number of receptors getting blocked. From 60%, it can become 75% or 80%. So once it becomes 75 or 80%, patient will have residual neuromuscular palsy. Okay, one is hypothermia. Okay, any other thing?
if the patient's acidosis.
Acidosis is very common in the postoperative period.
No,
It's not
Very common.
not very.
It's so common, respiratory acidosis. What do you mean by respiratory acidosis anyway? Just a question like that. What do you mean by respiratory acidosis? When do you say patient has respiratory acidosis? What is respiratory acidosis? It's a simple question, respiratory acidosis.
pH less than 7.35.
That is acidosis. Anything less than 7.4 pH, you call it as acidosis. When do you call it as respiratory acidosis?
When PCO2 is
Yes. If carbon dioxide is high.
More.
when PCO2 is more than 30.
Yeah, when carbon dioxide levels are more than 45 to 50. Normally is 35 to 45 is normal. The PaCO2, partial pressure of arterial carbon dioxide. If it crosses 45, you call it as, and that can reduce the pH, because carbon dioxide is a volatile acid. If the volatile acid is increased in the body, so it is not getting excreted out, patient is hypoventilating, and most common cause of respiratory acidosis is postoperative hypoventilation. And so many of your patients may be hypoventilating in the postoperative period. One of the causes can be because of the residual effects of neuromuscular blocking agents, obstructed airway itself. And there can be continuation of many of the drugs what we use intraoperatively, the opioids. They can produce central respiratory depression, the benzodiazepines, and our induction agents, maintenance agents. Many of these drugs will continue to produce hypoventilation, isn't it, in the postoperative period. And any hypoventilation can produce decreased expiration of carbon dioxide. Once decreased expiration of carbon dioxide occurs, carbon dioxide accumulates, and any PaCO2 more than 45 will start decreasing the pH. And this you call it as respiratory acidosis, isn't it? So for every 1 millimeter increase of PaCO2 above 40 millimeters, there is a pH change, acute pH change of 0.008. This you should always remember. Every 1 millimeter change of or increase of PaCO2 will decrease the pH by 0.008. Suppose if it is 10 millimeters increase from 40 to 50, 10 into 0.008 is 0.08, isn't it? 7.4 minus 0.08, it will be 7.32. So pH will come down to 7.32 if there is any increase in the carbon dioxide level. From 40 to 50, it has gone. So respiratory acidosis. So definitely if the patient has developed a hypoventilation in the postoperative period and the respiratory acidosis has occurred, this is going to produce residual neuromuscular palsy. This you should always remember. Any metabolic problem as far as acid-base balance can produce residual neuromuscular palsy. Not the respiratory, metabolic. Metabolic means it is always associated with bicarbonate. Any decrease in bicarbonate, you call it as metabolic acidosis. Any increase in bicarbonate, you call it as metabolic acidosis. Which produces more problem? Is it acidosis or alkalosis as far as residual neuromuscular palsy is concerned?
Acidosis.
Opposite. It is alkalosis. The more important thing is the metabolic alkalosis, because you know that whenever metabolic alkalosis occurs, potassium will move into the cells. The extracellular potassium levels will come down. Transmembrane potential will get altered. There is hyperpolarization at the neuromuscular junction, and that it is going to produce again decrease in the tone of the muscles. It adds to the residual neuromuscular palsy. So metabolic alkalosis, respiratory acidosis are very important. Hypothermia is again important. And as we discussed, drugs like any aminoglycoside antibiotics, if they are given, that can produce. Now, many times when you do not have the quantitative monitor, you will try to use certain, clinical signs, isn't it? So some of the signs were called as totally unreliable signs, which you are still using many times. As soon as the patient comes out, you want to use these signs. And some of the signs, though they were called as more reliable, but still now we know they are less reliable. So what are the clinical signs usually you use? Less reliable signs, like what you will ask the patient once you have reversed the patient.
Sustained a head lift for more
There
than
are more reliable signs, isn't it?
Yes.
Yes.
Normally, you don't ask the patient to lift this.
Protrude the tongue.
we
Yeah.
ask to protrude the tongue,
Before that,
open the eyes.
yeah, open the eyes. You will always ask the patient to open the eyes, then protrude the tongue. So ask him to lift his hand, isn't it? So these are some of the, and ask him to take deep breaths. You want to check with you hold a mask and then you want to check with your bag. Is he having enough tidal volume or not? Isn't it? So all these are very, very poor, signs as far as the neuromuscular recovery is concerned. Totally unreliable signs, but we still use them. If the patient is able to open his mouth and protrude his tongue, open his eyes, you think, oh, okay, everything is fine. Okay, come on, shift. That is what even I was doing like that, and everyone does it, isn't it? Now, the other thing which probably, if you see the older books regarding even Miller, probably 7th edition Miller, he has given more reliable signs. Now you are able to tell these more reliable signs, but later they have been proved less reliable. What are these more reliable signs which we try to elicit?
Sustain the head lift for more than 5 seconds.
Yeah, very good one.
Sustain leg lift for more than 5 seconds.
Yes, very
Hand
good.
grip, sir. Sustain hand grip.
Sustained hand grip for more than 5 seconds.
And this
Tongue depressor test.
Yeah, that is supposed to be more reliable because it will check the airway muscles, isn't it? Whether the airway muscles have come out or not. What is this tongue depressor sign?
so hold the tongue depressor firmly between the incisor and patient should bite it.
And then what you are going to do?
Patient is able to move.
Whether patient able to bite the incisor.
No, he'll be maybe
Right.
biting or may not be biting. You are trying to use moderate force to pull it out.
Pull it out. Yes.
So you should not be able to pull it out with moderate force. That means he has developed enough power of his airway muscles to, hold the tongue depressor between his incisor teeth, isn't it? So this is called as a tongue depressor sign. Okay, any other, signs you look for other than these?
We'll check the peak inspiratory pressure.
Pressure.
Not peak inspiratory, it is called as the maximum inspiratory force or maximum inspiratory pressure, isn't it? So that is another one which you will be checking. So it is actually the maximum inspiratory pressure is a negative pressure. So you require to have a specially designed equipment for doing this. So there is a T piece. To one end of the T, you have got a monitor attached. Sorry, you have got a pressure monitor attached. So other end is open with a valve. It will allow only inspiration. Sorry, it will allow only expiration. It will not allow inspiration. So one end is kept in the mouth of the patient. So one end is kept in the mouth of the patient. Another end, you have a pressure monitor is there. In the other end, it has got a valve, the T, and which will allow only expiration, not inspiration. It will block during inspiration. So when the patient is asked to take a deep inspiration, so the valve is closed, he is taking a deep inspiration against a closed valve, and directly the pressure he is creating, the negative pressure he is creating, will be seen in the pressure monitor you have. So how much of pressure he is creating. So normally we were thinking if you can create more than minus 25 centimeters of water, it is enough. But actually, it is enough for the patient to breathe with the endotracheal tube in situ. If you take out the endotracheal tube, there is going to be a collapse of the airway. So ideally, it should be more than 40 centimeters of water, minus 40 centimeters of water for maintaining the patent airway. But still it is not enough because you require the patient to cough well in the postoperative period to bring out secretions. So that requires a maximum inspiratory pressure of minus 60 centimeters. Just to breathe with the endotracheal tube there in situ, it is minus 25 centimeters of water is enough. And if you take out this thing to prevent airway collapse, it requires minus 40 centimeters of maximum inspiratory pressure. And it's actually the inspiratory muscle strength it will be checking. And for coughing, it requires about minus 60 centimeters of water pressure. So these are one of the important things, but minus 25 centimeter is not enough. Okay, now coming to the antagonism. That is all about the residual neuromuscular palsy. We have discussed in detail about the residual neuromuscular palsy. What are the factors which can produce residual neuromuscular palsy? What are the consequences of residual neuromuscular palsy? And now it is very important to monitor the patient using a quantitative monitor to detect residual neuromuscular palsy and also to prevent residual neuromuscular palsy. That is very, very crucial, so that you should always understand. Now, coming to the antagonism of neuromuscular blocking agents, what are the different methods of antagonism we have?
Competitive,
Pardon?
reversible, irreversible.
No, what are the
Competitive
different methods of reversing or antagonism? Reversing or antagonism are same. One regularly conventional antagonism you are producing or conventional reversing you are producing. What is that? What is that type?
Recep-
You are
Recep-
trying to increase the level of acetylcholine at the neuromuscular junction, isn't it?
comp-
By using an anticholinesterase. That is one of the conventional methods, is to use an anticholinesterase drug to increase the level of acetylcholine at the neuromuscular junction, so that it can compete with the non-depolarizing muscle relaxant molecules, and it can reverse. That is what is called as a conventional way of reversing that is being used. It started from 1952, and we are still using the conventional method. What is the other non-conventional method which has been introduced? No, we have Sugammadex, isn't it?
Yes, sir.
Sugammadex is a non-conventional one. It is not going to increase the acetylcholine level at the neuromuscular junction, isn't it? It binds to the neuromuscular blocking agent, isn't it? So it's entirely a different type of antagonism it produces, or different type of reversal agent, isn't it? So these are two of the different types of reversal we use. A conventional method of reversal, and another is a non-conventional method of reversal where we use a binding agent. So this binds to aminosteroid molecules like vicuronium or rocuronium, and does make them inactive, so that the patient gets reversed, isn't it? So let us talk about the conventional methods first, and then we will go to the non-conventional agent, that is Sugammadex. Okay, conventional method already we had discussed. So what are these anticholinesterases that are commonly used for reversal of neuromuscular junction block?
Neostigmin, hydrophonium, pyridostigmin. We commonly
very
use
good.
neostigmin.
So these three are the common reversal agents that were used. Neostigmin, hydrophonium and pyridostigmin. Already last time I asked few questions regarding this. So we still are very happy with neostigmin, isn't it? We use only, how many times you have used pyridostigmin or hydrophonium?
Never.
We
I
have
have
not.
never used, of course. I have never seen the ampules also.
Yes.
Always neostigmin, isn't it? So last time I had asked you why hydrophonium and pyridostigmin are not usually used. Why neostigmin is more commonly used.
Hydrophonium has faster onset
And
and
that is good, isn't it? Faster onset of action is good. We don't want a drug to act very slowly. That is one of the advantages of hydrophonium.
it has early on short duration.
One main problem with hydrophonium is shorter duration of action. So that especially when you are using long-acting muscle relaxants, it may not be effective, because still the effect of non-depolarizers, long-acting non-depolarizers may be there in the body. They're still there in the plasma. So recurization problem can occur, isn't it? So hydrophonium may not be an ideal area. But last time I also asked you where hydrophonium is more commonly used. To differentiate what?
Myasthenia gravis
Myasthenia?
crisis.
Myasthenia crisis
Sir.
and what is the other crisis?
Myas-
Cholinergic crisis,
Cholinergic crisis.
crisis.
Yes.
isn't it? Hydrophonium is the drug of choice to differentiate between myasthenic crisis and cholinergic crisis. What is myasthenic crisis?
Respiratory.
Patient has not taken his drugs. Usually, he'll be on anticholinesterases. Myasthenia gravis patient, he or she, usually it's she, because myasthenia gravis is more common in young females. So should be using these anticholinesterases. For example, now if she has not taken these drugs, So she'll go for extreme paralysis, isn't it? So that is what is called, she'll go into a crisis, which is called as myasthenic crisis, myasthenia crisis. What about cholinergic crisis? The opposite. What is the opposite?
That.
What is the opposite of myasthenia crisis? Cholinergic crisis. She has taken too much of these drugs. There is excess release of acetylcholine. Excess of presence of acetylcholine can again produce paralysis, isn't it? So that is called as cholinergic crisis. Now you are walking in a emergency room, ER, and the patient is brought there, known myasthenia gravis patient, and with complete paralysis. Now you'll have to know whether it is due to myasthenia crisis or is it due to cholinergic crisis. So how hydrophonium will help? Giving IV hydrophonium.
So the test 10.
Suppose I use IV hydrophonium for a patient with myasthenia crisis. What will happen to the patient? Will there be improvement or still deterioration?
There will be an improvement.
Pardon? Correct?
There will be an improvement.
Yeah, there will be improvement because it is because of not taking the anticholinesterase. Hydrophonium is an anticholinesterase. It improves the neuromuscular junction function, so that the patient will recover. The patients will start breathing. Patient will start developing motor power, isn't it? Suppose if it is cholinergic crisis, what will happen? Will there be more deterioration or?
More deterioration.
Yeah, more deterioration because it is going to further increase the amount of acetylcholine. Already there is a huge amount of acetylcholine at the neuromuscular junction. Further increase that can produce cholinergic crisis, isn't it? So hydrophonium, because it's a rapid onset, within 1 minute it starts acting. That is the reason why hydrophonium is used for differentiating. So sometimes you may be asked about this question. So just remember about that. And pyridostigmine, why it's not used for reversal as such?
Long acting, sir.
Yeah, what is the problem if it is too much long acting? Onset of action first is much longer. It will take almost 15 minutes to start acting. That is one problem with pyridostigmine. Another is duration of action is longer. Now, what happens if the duration of action is longer? Longer than your anticholinergic drugs.
So
All the
that-
side effects of anticholinergic will start, isn't it?
yes.
So we'll come to what are the side effects of anticholinesterase later. So all the side effects, because it is continued to present in the body, so it can produce and usually you will be using anticholinergic drugs also along with anticholinesterase, isn't it? So the effect of anticholinergics or antimuscarinic agents, what we call it as atropine or glycopyrrolate, would have already gone, but still the effect of anticholinesterase, pyridostigmine can be there, and it can produce a lot of problems because of its effect on its effect on muscarinic receptors and also on the nicotinic receptors. So that is the reason why pyridostigmine is also not commonly used. Right. So more commonly what we use is neostigmine. So last time we were discussing about something called as a ceiling effect as far as neostigmine is concerned. What is the ceiling effect and why it occurs?
Sir, the increased amount of neostigmine will not
Produce any effect after certain points, sir.
Why? You're correct. Why?
Already sensitized receptor.
No, nothing to do with that. So it can increase the amount of acetylcholine to a level, isn't it? It cannot further increase because whatever the acetylcholine that can increase because of the anticholinesterase you use can be to a particular extent. further dose increase in neostigmine cannot further increase the acetylcholine levels. So once it cannot further increase in the acetylcholine at the neuromuscular junction, so further increasing the dose will not help. And that is the reason what we call it as a ceiling effect. Isn't it? So how does it increase the acetylcholine level at the neuromuscular junction? How does it increase?
So by breakdown of it will prevent the breakdown of acetylcholine.
It's very good.
Blocking
How
the
choline is normally,
administration.
metabolized or broken down at the neuromuscular junction?
So it is hydrolyzed by enzyme cholinesterase.
What cholinesterase? It is a pseudocholinesterase or acetylcholinesterase?
Acetylcholinesterase, sir.
It is acetylcholinesterase, which is present at the neuromuscular junction, because pseudocholinesterase or plasma cholinesterase is not present at the neuromuscular junction. So it is always the acetylcholinesterase which actually breaks down this or hydrolyzes acetylcholine, which is released from the presynaptic nerve ending, isn't it? Last time I told you, it is so fast. It breaks down almost 4,000 molecules of acetylcholine per second.
Yes, sir.
Almost 50% of the acetylcholine will be metabolized before actually it reaches the motor end plate. Only 50% of the acetylcholine can reach the motor end plate and act on the nicotinic receptors. Other 50% gets metabolized very rapidly by acetylcholinesterase. Now you are using a drug which blocks this acetylcholinesterase, isn't it? So it has got two sides. What are these two sides?
Nicotinic and muscarinic.
Last time you people only had
Two alpha subunits.
no, the acetylcholinesterase. I'm not talking about the nicotinic receptor. What are the two sites wherein the the anticholinesterase will go and occupy and then produce prevention of hydrolysis of acetylcholine? It has got an anionic site and an esteratic site. Last time you people had answered and you have forgotten already. So an anionic site and an esteratic site. So the anticholinesterases, whether it is neostigmine or hydrophonium or pyridostigmine, they all will go and then, they get associated with both anionic site and the esteratic site. And it is a combination with the esteratic site, which is very important for prevention or for inhibition of acetylcholinesterase. So that's how, acetylcholinesterase gets inhibited. So because it is a competitive antagonism at the neuromuscular junction by the non-depolarizing muscle relaxants, so you give the anticholinesterase, so acetylcholine levels will increase. So once the acetylcholine levels will increase, so it can compete with the neuromuscular blocking agents molecules and push the molecules out of the nicotinic receptors, occupy the nicotinic receptors, and the patient can get back the motor power. So that is why competitive antagonism. So you increase acetylcholine levels. So this increase in acetylcholine levels can be only to a maximum levels, isn't it? Can not increase. That is what we call it as a ceiling effect. Okay. So at when ideally the neostigmine should be administered. So okay, you are monitoring the neuromuscular junction using a quantitative monitoring. So when you should actually give, so that there will be a very fast reversal of the neuromuscular junction.
When the patient starts taking a spontaneous breath.
Now, is it enough?
TOF
And TOF should
anything
be
more than
0.9.
0.4.
Yeah, very good. So the patient should be in the minimal block. That is what you call it as minimal block, isn't it? 0.4 to 0.9, Trainer-4 ratio. So effective reversal can occur only when the patient's Trainer-4 ratio is more than 0.4. Then only the neostigmine can, rapidly can produce increasing the level of acetylcholine and can this increase in acetylcholine levels can compete with the neuromuscular blocking agents at the neuromuscular junction, and patient can get back the power. Why this is very important? Why 0.4 and above is important?
To avoid residual blockades.
That is okay, but how avoids residual blockade? Why this 0.4 is important? No, it's very simple, isn't it? Because when it is 0.4 already, the train of 4, that means the train of 4 count is 4. That means the number of receptors that are blocked at the neuromuscular junction is very less, isn't it? That means the number of molecules of non-depolarizers at the neuromuscular junction has come down. Most of the molecules have already moved into the plasma to the liver or kidney and then metabolized, and they are not there at the neuromuscular. If they are less in number, because the competition can be better, isn't it? So the acetylcholine can, compete better because the rise of acetylcholine molecules will be able to throw whatever the remaining neuromuscular blocking agents and can occupy and then can produce the reversal, isn't it? So suppose the patient has got a moderate block or a deep block or an intense block. Can I use neostigmine to reverse?
No, sir.
Why not? Again, there is the same reason. You can repeat.
Because
The same reason just now I told you. When there is deeper intense block, what will be the number of molecules of
it is high acetylcholine.
Too many, isn't it?
There's too many at the receptor
Too
sites.
many occupying the receptors. So even the maximum level of acetylcholine you can produce by blocking the acetylcholinesterase enzyme will not be sufficient enough to compete with the more number of molecules, isn't it? So that is the reason why there won't be any reversal. That is why if you have just now I have given a non-depolarizing muscle relaxant. For example, rocuronium I have used for rapid sequence induction. I have used 1.2 milligram per kg body weight of rocuronium. I'm not able to intubate. Can I give neostigmine and reverse? I produce an intense block.
No, sir.
I'll not be able to. That is one of the drawbacks of your neostigmine. It will not be able to reverse an intense block or a deep block or even moderate block. It will take a long time to reverse the moderate block. Moderate block means trinophore count is 2, 1 or 2 trinophore count, but trinophore ratio is 0. So when trinophore count is 2, if you give reversal agent, it will take a longer time to reverse because still the number of molecules of non-depolarizers are much higher at the neuromuscular junction. I hope you have now understood, isn't it? Why, if there is deep block, intense block, or moderate block, neostigmine may not be able to reverse. So that's why when we want to give neostigmine, suppose they are using neuromuscular block monitor, neuromuscular junction monitor, like a quantitative monitor, it is fine. Okay, trinophore ratio is 0.4 and above, I can now give neostigmine. But if you are not monitoring, then will be the problem. Then you have to look for adequate movement of the patient, his breathing, he is able to open his eyes, he is able to lift his head, he is able to have a sustained hand grip. So when he is able to do all this, now you know that his the trinophore ratio would be around 0.4 or just above 0.4. Now is the time to give reversal. Don't try to give reversal when the patient is not showing these kind of clinical signs. Okay, this is a practical thing you should always understand. When the patient, that is why you have to wait for the patient to have these clinical signs before you can reverse the patient. Before that, there is no point in trying to reverse because the patient will not get reversed with neostigmine. Hope you have understood, isn't it? Why these clinical signs matter for giving the reversal. So if he can able to lift his head, he is able to breathe well, he is able to lift his hand, now you can reverse the patient, and within few minutes the patient will get reversed. And another important thing regarding the pharmacokinetics of neostigmine. So how much time it will take to actually act, and when it peaks, when the effect will peak.
Onset of
Onset is-
action is 5 to 10 minutes, sir.
5 minutes is the onset of action,
5 minutes.
and peak effect can be around 10 to.
Up to 10 minutes.
7 to 10 minutes.
Yeah. So you have given now the neostigmine and anticholinergic like atropine or glycopyrrolate. How long you should wait till you extubate the patient?
7 to 10
10
minutes.
minutes, sir.
Isn't it? So that is another very important thing. So you just give and don't try to extubate the patient, because your reversal agent like the neostigmine would not have started to act. So there is no point in trying to extubate the patient when the patient has not, when neostigmine has not completely acted, and then it has reversed the patient. Okay, now along with neostigmine, you always give an anticholinergic. Last time also I had asked, why should you give an anticholinergic?
To minimize the muscarinic
Muscarinic
side
effects.
effects.
Yeah, muscarinic effects. So because once you increase the level of acetylcholine is going to act on both nicotinic receptors and the muscarinic receptors. And to nullify the effect of acetylcholine on the muscarinic receptors, you have to use an anticholinergic drug. So because you know that neostigmine starts acting almost about 5 minutes after you administer intravenously. What about glycopyrrolate, when it starts acting?
3 to 5 minutes.
What is the onset of action of glycopyrrolate? What is the onset of action of atropine?
Atropine is
in
1 minute, sir.
less than
Less than
Atropine is 1 minute. Very good. Glycopyrrolate,
glycopyrrolate is
3 to 5 minutes.
2 minutes.
okay.
Glycopyrrolate is 2 minutes. Atropine is 1 minute.
Okay.
And neostigmine is 5 minutes. So which will start acting first then? Anticholinergics or anticholinesterase?
Anticholinergic starts acting.
Yeah, isn't it? Anticholinergics will start acting. So should you give first anticholinergics and then give neostigmine, or can you mix both in the same syringe and then can give?
We are
What you are doing actually?
mixing and only giving.
Yeah, mixing and you are giving. So before actually, when I was a postgraduate student, what we used to do is we used to load, then glycopyrrolate was not available, only atropine. So first we used to load atropine, we used to give atropine first. We want to block the muscarinic receptors before giving neostigmine. We never used to mix in the same syringe. Later, when we came to know that even when you mix the two drugs and then introduce intravenously, it is always the glycopyrrolate which acts first, or atropine which acts first, and neostigmine acts later. So by the time neostigmine acts, already the muscarinic receptors are blocked by the either glycopyrrolate or atropine. So there won't be any problem. So mixing of these two drugs is fine. There won't be any problem in mixing. That is the reason why you have a ready prepared mixture is also available.
Okay.
So you have both the glycopyrrolate and neostigmine mixed in the same ampule, and we are getting, isn't it? So that way there is absolutely fine in mixing and then giving. So one more question I want to ask you here is, suppose you have used atracurium or cisatracurium. Do you require to reverse or you don't require to reverse?
We recommend to reverse.
No, because atracurium and cisatracurium, they have half months elimination and ester hydrolysis. They don't require liver or kidney for their elimination. Organ independent elimination of these drugs. Should you use or should you not use?
Fish.
Now, are you routinely reversing atracurium?
Reversing.
Reversing, sir.
Yeah, because, if you are quantitatively monitoring the patient, and if your trainer 4 ratio is more than 0.9 after giving atracurium, you don't have to reverse. Okay. You're
Okay.
doing a quantitative monitoring and you have found that the patient has completely come out of atracurium and his trainer 4 ratio is more than 0.9 or it may be even 1 of acceleromyography. So there is no need to give reverse. That is the only time you need not have to give reverse. Otherwise, if you are not monitoring the patient with a quantitative monitor, you need not have to, you have to reverse with neostigmine. So routinely you will not be monitoring. That's the reason it is always better to reverse. Okay, now coming to the dose of neostigmine. What is the dose of neostigmine you are required to give based on if you are using a quantitative monitor?
40
40
to
to
70
70
mics per
mics per
kg.
kg. It's huge.
That is when you are monitoring for example, now let us say that you are monitoring the neuromuscular junction with a quantitative monitor and trainer 4 ratio is 0.6. It is more than 0.4. What is the dose of neostigmine? Is it still 40 mics to 70 mics per kg body weight?
I guess it is the same.
No, you require to give less or you require to give more. When it is already,
Less.
the patient is almost recovering. You
We
don't
can-
have to increase so much of acetylcholine to compete.
Mm.
So it is just about 20 to 30 micrograms per kg body weight. If already it is more than 0.4, your trainer 4 ratio, you don't require to give 50 micrograms. Normally you give 50 micrograms, isn't it? 0.05 milligram per kg body weight is the dose. When you're asked in the exam, you always tell. But you don't require that much. That is 50 micrograms is not required when the patient has got about 0.6 or 0.7 of trainer 4 ratio. You just have to give 20 to 30 micrograms per kg body weight. So that is how, that is an advantage with monitoring, quantitative monitoring. So you can even reduce the dose of the reversal agent. Okay, now why should you reduce? What are the side effects of the neostigmine? What are the problems it can produce?
Bradycardia.
No, you classify that, isn't it?
Okay.
So you can classify that as cardiac
Car-
side effects, cardiovascular side effects, respiratory side effects, gastrointestinal side effects, and then muscular side effects. What are the cardiovascular side effects these can produce?
Pronounced vagal effect can be seen. So bradycardia.
Bradycardia,
The muscarinic effect on the heart, isn't it? Muscarinic effect on the heart, like bradycardia. So SL
functional.
function. So there can be junctional bradycardia also can occur, isn't it? Or there can be even heart blocks can occur. First degree, second degree, or even complete heart block can occur with neostigmine. And many times, I don't know how many times you have observed, some of these patients, in spite of you have given a glycopyrrolate, still they do develop quite a bit of bradycardia after reversing. Have you seen some of the patients? Because you are continuously anyway monitoring the patient also with pulse oximetry. And many of these patients do develop. I have seen quite a bit of resistant bradycardia some people develop after reversal. Even though you give extra dose of atropine also, the heart rate will not pick up. I've seen such patients. So one of the problems with neostigmine is, bradycardia and heart blocks and junctional rhythm, junctional bradycardia is very common. So those are the cardiovascular side effects. What about the respiratory side effects?
Increase the secretions, bronchial
The one
secretions.
is increased bronchial secretions, then
constriction.
bronchoconstriction, especially in those patients who have got an hyperreactive airway disease. So that is why many times in these patients with hyperreactive airway disease, So people were reluctant to give neostigmine atropine or neostigmine glycopyrrolate to reverse. So they used to, take the patients to the ICU, continue to mechanically ventilate. So till the patient comes out of neuromuscular blocking agent, so that they can extubate. So because they always had this, problem of developing bronchoconstriction, because they are highly prone for it, because they have got a hyperreactive airway disease. So they, the anesthesiologist used to think that neostigmine can produce this problem. So that's why they never used to use reversal agents in such patients. So that is one of the respiratory side effects of neostigmine. Okay. Coming to gastrointestinal side effect.
Involuntary,
Gastrointestinal. Increase in acetylcholine levels can produce actually what effect on the intestines? Increased acetylcholine levels.
Motility is increased.
Yeah, increased motility, isn't it? Vagotonic effect. Vagotonic effect is increase in the motility. So, for example, now a surgeon has completed an anastomosis, end-to-end resection and end-to-end anastomosis of the intestines. If suddenly, if you use neostigmine and there is a sudden increase in the motility of the intestines, so what can happen to this anastomosis?
leak.
It can give way, isn't it? And anastomosis can give way, and the patient may have to be brought back for a repeat surgery, isn't it? So that is one of the theoretical side effects of neostigmine because of its effect on the gastrointestinal system. What about on the muscles? What is the direct effect of neostigmine on the neuromuscular junction and the muscles?
Muscle contraction.
No, it produces contraction, or it can by itself can produce paralysis.
Higher doses can lead to paralysis.
Isn't it? Higher doses can lead to paralysis.
Yes,
Just
sir.
like your organophosphorus compound, how it produces paralysis. Because the increase in acetylcholine levels can produce a depolarizing type of block, like succinylcholine. Or even if it is prolonged, it can even produce a type 2 block, or a mixed block, or a dual block at the neuromuscular junction. So they have found in many of the volunteers, when only neostigmine has been given, it has produced weakness of the muscles, the skeletal muscles. So that is another important drawback of the neostigmine. All these are the side effects of neostigmine. It can produce weakness of the muscles, it can produce bradycardia, it can produce increase in bronchial secretions, bronchoconstriction, it can even increase the motility of the intestines. And another problem is it can also increase postoperative nausea and vomiting. PONV incidence can be, though it's controversial, but it is said that it can increased incidence of postoperative nausea and vomiting. That is the reason why, if you are using a quantitative monitoring, you can definitely reduce the dose. You need not have to give the full dose. Okay, suppose if you are monitoring the patient and the Trainer-4 ratio is 1, more than 0.9, and even it is 1. So should you still reverse the patient? Or you need not have to reverse the patient?
For vecuronium, sir.
No, whatever it may be, vecuronium or atracurium or whatever it may be. So it is 1 now, Trainer-4 ratio. By, if you are thinking about the neuromuscular junction, you think that more than 30% of the receptors are free from the blocking agent. So still, should you give, or you need not have to give now?
You need not have to give.
Yeah, that is very important. You need not have to give. So that's in order to unnecessarily prevent, because when you unnecessarily give, this itself can produce again decrease in the tone of the muscles. by increasing the level of acetylcholine there and then can produce a depolarizing type of block. That is why, your quantitative monitoring will help you. Unnecessary, you won't give neostigmine. If the trainer-4 ratio is more than 0.9 or 1, you will avoid giving neostigmine and atropine and all the problems of even anticholinergics, because they start acting first, and sometimes they can even produce quite a bit of tachycardia.
Yes.
Because I told you that atropine acts in 1 minute and glycopyrrolate will act in 2 minutes. And in patients where you do not want to produce tachycardia, they can produce tachycardia, like in patients with ischemic heart disease patients, or in patients with diabetic patients. So in many of these patients where you do not want any increase in heart rate, so in such situations they can increase the heart rate, these anticholinergics. So all these problems you can avoid by using a quantitative monitoring of the neuromuscular junction. Okay, so now coming to the metabolism of neostigmine, how does it gets metabolized?
So,
Primarily metabolized by plasma cholinesterase.
Hey, come on. How does neostigmine gets metabolized? It is going to block plasma cholinesterase. It is not going to be metabolized. Succinylcholine is metabolized by plasma cholinesterase.
yes.
And if you give neostigmine, because it is going to block plasma cholinesterase, if you give succinylcholine after that, there will be a prolonged duration of action of succinylcholine. How neostigmine gets metabolized?
It is metabolized in liver, sir.
Hepatic metabolism.
Hepatic metabolism.
How much? What is the percentage?
Or
Percentage metabolized in the liver, percentage excreted unchanged through the urine.
66% unchanged in urine. 60% unchanged in urine.
You are guessing. So it is 50-50. 50% it is metabolized in the liver, 50% excreted through the kidneys unchanged. So what happens in a patient who has hepatic dysfunction and renal dysfunction? The duration of action of neostigmine.
sir, it's if
No.
it is reduced in renal failures
No.
clearance.
If the patient has got a hepatic disease and a renal disease, because it requires both liver and kidneys for its excretion, what happens to the duration of action?
Prolonged.
It's prolonged. It's very simple to know, isn't it? So the duration of action of neostigmine definitely will be prolonged in patients with hepatic disorders and renal disorders, because it requires kidneys and liver for it to be metabolized and excreted. 50-50, 50% it is excreted through kidneys. For example, let us say that patient has got an end-stage liver disease, an end-stage kidney disease, and you have given neostigmine. So 50% of it should have been excreted through kidneys. Now it is not getting excreted out. It remains in the body. If it remains in the body, means it is going to have a prolonged duration of action, isn't it? So, but what is can it produce problems because of its long duration of action in patients with hepatic disorder and renal disorder? Can it have all these side effects, like on the muscles, on the cardiovascular system, on the bronchial system, that is the respiratory system, on the gastrointestinal system? Can it have?
Yes.
Yes, sir.
No, will not have. Because how your atropine and glycopyrrolate are metabolized? Because you are giving an anti-muscarinic agent, isn't it?
Yes,
How
sir.
they are metabolized?
It is metabolized
Atropine and glycopyrrolate.
liver only, sir. About half is metabolized in the liver.
You are sure?
Atropine is observed in the gut.
Exchanged in you.
Pardon?
Mainly hydrolyzed in liver only, so liver and tissue.
Not hydrolyzed. Don't, just like that, whatever comes to your mind, you should not tell. That is very important in the exam. So the examiner will catch you there, and then, you'll start asking questions about hydrolysis and dealkylation and glucuronidation, phase 1 metabolism, phase 2 metabolism, all those things. So how does because you are using every day. Are you using glycopyrrolate every day or you are not using?
We are using.
Then you should know how it gets metabolized, how it is excreted out. You should know entire pharmacology of these drugs. They're always on your anesthesia machine.
It's excreted urine, so glycopyrrolate is excreted in urine.
Only entire 100%, is it?
80% exchange in you.
No, don't guess. Don't try to guess. So if you don't know, you can always say, I don't know. That is one thing you should always remember in the exams also. Don't try to guess, and then if you do not know, you can always say that particular question so that the examiner can answer or he can go for the next question. So it is again the same thing, 50% metabolized in the liver, 50% excreted through the kidneys. So what happens to the duration of action of glycopyrrolate or atropine when you are mixing it with neostigmine and giving? What happens to the duration of action of these anticholinergics?
Will be prolonged.
That also will be prolonged. So what is the problem now? Neostigmine is also having a prolonged duration of action, and glycopyrrolate is also having a prolonged duration of action. Glycopyrrolate is blocking all the muscarinic effects. So the patient will not have any sort of side effects of neostigmine, even though patient may have liver problems or kidney problems. When you're using an antimuscarinic agent, because antimuscarinic agents like glycopyrrolate and atropine also depend on liver and kidneys for their excretion, so there won't be any problem. Actually, prolonged duration of action of neostigmine will help in completely reverse the the neuromuscular blocking agent, isn't it? So it produces a higher margin of safety. So you can safely use neostigmine and glycopyrrolate in patients with liver disorders or in patients with kidney disorders. So this is about all these about the conventional method of reversal, that is using anticholinesterases, their side effects, their metabolism, that is the pharmacokinetics, pharmacodynamics, and the dose what you have to give. So dose depends on your neuromuscular monitoring, quantitative monitoring. You can definitely reduce, or you can totally avoid if the trainer 4 is 0.9 or 1. You need not have to give neostigmine, and especially so with atracurium or cisatracurium, because they get metabolized in the blood itself. So these are all the things about neostigmine, other anticholinesterases. Coming to the unconventional method of reverse, that is Sugamadex, isn't it? So why it is called as Sugamadex? It's a common short notes you'll have first paper, Sugamadex. So many times it has been asked.
Chemical stuff. It's a gamma cyclodextrin.
Modified gamma cyclodextrin.
It's very good. And why Su?
Tr-
Modified gamma cyclodextrin, gamma dex is fine. Why Su gamma dex? Why SU? Su?
Sugar.
Yes.
Sugars.
Yeah, it contains a sugar molecule. So sugar containing gamma cyclodextrin. That is why it is called as, the name has been given as Sugamadex, isn't it? So first time when I read about Sugamadex in 2005, so I was really, what is this Sugamma? I was, pronouncing it as Sugamadex. Like, in South Indian, some females name like Sugamma or Sakamma or something like that. So I was really perplexed by the name. Of course, why the name has been, and then I started reading about it. Then it is a sugar containing gamma cyclodextrin. That is why it is called as Sugamadex. So when it was invented, and who introduced Sugamadex?
It was
2005.
2005, sir.
Yeah, 2005. So when actually the experiments started getting done in 2005. When it was officially used?
2000 after 15.
Pardon?
2015.
2021.
2008. 2008 only they started using it in majority of the countries except US. US only after 2015. Till 2015, they were not using it. Okay, so who introduced this? The name of the person who introduced? Sigma-Dex. Who introduced? Is atom bomb. ATON, atom, BOM, bomb. What was he? Atom bomb. It is not atom bomb. It is atom bomb, BOM. What was he actually?
Can I-
Pharmaceutical chemist.
Yeah, very good. So he was a scientist, pharmacy scientist. He was working with which company? He was working with Organon. So what was he trying to find out when he was using this gamma cyclodextrin for rocuronium? He wanted to use a solubilizing agent for rocuronium. He was trying to find out because these gamma cyclodextrins are commonly used for food supplements as solubilizing agents. So he was thinking that by using gamma cyclodextrin, so he may actually use it as a solubilizing agent, as a preservative along with rocuronium. But for his dismay, actually he found out the activity of the rocuronium completely gone when he combined gamma cyclodextrin along with rocuronium. There will be total inhibition of the activity of the rocuronium. Actually, he wanted to try it as a preservative, as a solubilizing agent. Then, he realized that it could be used as a reversal agent for rocuronium. That's how, it was an accidental invention. Sigma-Dex is an accidental invention by Attenbaum, who was a pharmaceutical research, fellow in Organon company. That's how Sigma-Dex was introduced. So how Sigma-Dex produces antagonism of neuromuscular blockade? Because it is not conventional. Conventional is to increase the acetylcholine level. Sigma-Dex is not going to increase the acetylcholine level. So how does it reverse?
So it encapsulates the neuromuscular blocking agents. So.
Okay, which neuromuscular blocking agent?
Rocuronium,
Aminosteroid.
aminosteroid.
Aminosteroids, so vicronium and
Rocuronium.
then rocuronium, pancuronium, pipecronium. So these drugs are aminosteroids. So it's going to encapsulate. So how does it produce this encapsulation?
Because it's a hollow truncated cone structure.
Yeah, okay. It has got a hollow
Hydrophobic
inside.
cavity and
Cavity
a
and a
hydrophilic.
We call it as a donut shaped molecule. It is a donut shaped molecule. You know what is donut? Isn't
Yes.
it? So it has got an exterior and an interior. What is the exterior part of the Sigma-Dex? What is the interior part of the Sigma-Dex as far as lipophilicity or hydrophilicity is concerned?
So it is hydrophobic.
Cap inside and then hydrophilic exterior.
Yes, excellent. So it has got the hydrophilicity, the exterior, and hydrophobicity in the interior. Now, how does it produce encapsulation of aminosteroids? These aminosteroids have got mainly two parts. One is a steroid part and another is a quaternary ammonium part. Listen, that's why they are called as aminosteroids. Quaternary ammonium, that is NH4, and a steroid, nucleus. So that's why they are called as aminosteroids. So which particular part of Sugammadex will take in the steroid nucleus, or which part will hold the amino part,
Like
the ammonium.
the inner part.
So the quaternary ammonium part will get bind to the exterior, which is hydrophilic part of the Sugammadex. And the steroid nucleus will enter inside, and which is taken in because the interior is the hydrophobic part. So it takes in the steroid part inside. Outside, it is the quaternary ammonium part of the aminosteroid is bound to the hydrophilic part exterior. So that's how this bondage will occur. So what if the binding of the molecules of the aminosteroid occur in the blood or in the neuromuscular junction, where
Blood.
the binding occurs?
Blood.
It occurs in the blood. So now how it reverses? How the reversal will occur?
So on entering the drug blood, it will
It
encapsulate the
Circulating
aminoacid,
aminosteroids.
Then what happens?
and then forming a complex in the plasma, and it renders as active.
No, once it produces a complex with aminosteroid drug, now what will happen to the free drug concentration of the aminosteroid in the blood?
All the free drug will reduce.
Yeah, all the free drug will become almost zero. Now, if free drug concentration becomes zero, now what will happen now?
You become inactive.
No, because the drug is still there at the neuromuscular junction. That is the effector site. That is the one which is producing actually the paralysis.
It dissociates from the neuromuscular junction.
Why it dissociates? You're correct. It dissociates. The molecules of non-depolarizing aminosteroid molecules bound to nicotinic receptors, they come out of the receptors. Why they come out of the receptors? Because a concentration gradient is created now. The concentration in the plasma of the free drug is zero. Now it starts pulling all the molecules that are present at the neuromuscular junction because the gradient is created now. So all the molecules get dissociated from the nicotinic receptors at the neuromuscular junction. They start entering into the blood. They start pouring into the blood very rapidly. Once they enter the blood, what happens? The free molecules.
It decreases.
No, the free molecules which were bound to the neuromuscular nicotinic receptors, now they get dissociated from there. Now, once they get dissociated, they enter the plasma. As soon as they enter the plasma, what will happen now? Again, Sugammadex molecules are waiting, isn't it? They just engulf all these molecules of rocuronium or vecuronium, isn't it? So they draw the molecules from the neuromuscular junction, then they encapsulate it, make them inactive. Totally, they become inactive now. So that's how, once the concentration of non-depolarizing muscle relaxants, aminosteroids, at the neuromuscular junction becomes almost zero, the patient will get back his muscle power. Now you understood how it reverses.
Yes, sir.
It's nothing to do with the competitive antagonism like anticholinergics will do. It will not produce any increase in the acetylcholine levels. It is going to decrease the free drug concentration in the plasma by binding. That's why they are called as binders. They're called as agent binders. So they bind, they produce inactivity, they produce almost, minimal free drug concentration. Once there is a minimal concentration of the aminosteroids in the plasma, so they pull the molecules from the the junction, and all the molecules will enter the plasma and they get bound to Sugammadex. So totally get inactivated. So that's how rapidly the patient can come out of the neuromuscular blockade by using Sugammadex. So fast. How fast it can, reverse the patient?
Within minutes.
Because we know that neostigmine will take about 15 minutes actually, 10 to 15 minutes. How fast your Sugammadex can reverse?
2 minutes.
Yes, just 2 minutes. Even many times, even less than 2 minutes. It all depends on, how much of the neuromuscular blockade is there, how many molecules of rocuronium or vecuronium or pipecuronium or pancuronium are there. So which one produces faster reversal among these aminosteroids? You have rocuronium, you have vecuronium, you have pancuronium.
Rocuronium, sir.
The rocuronium, it reverses faster than
Then
Vecuronium.
vecuronium
and
and pancuronium.
why?
Right. Mhm.
Why this? That is because among them, the smallest particles are rocuronium. Compared to vecuronium, vecuronium is slightly larger because the molecular weight of rocuronium is 502, whereas the molecular weight of vecuronium is 636. The molecular weight of pancuronium is still higher. What is the molecular weight of rocuronium, the Sugammadex? Molecular weight of Sugammadex.
100.
Pardon?
2000.
Yes, very good. You are correct. It is 2002. It is exactly 4 times the molecular weight of rocuronium. Exactly 4 times the molecular weight of
Okay.
rocuronium is Sugammadex. Why should you know that it is exactly 4 times the molecular weight of Sugammadex, of rocuronium?
Okay.
The molecular weight, if you think, it is 1:4.
Mhm.
Sugammadex is 4 times heavier than rocuronium.
Mhm.
Why should you know? And what is this binding? Is it 1:1 binding or how the binding occurs?
1:1.
Yeah, 1 molecule of Sugammadex binds 1 molecule of rocuronium. So now regarding the molecular weight, as far as the dose is concerned, what should be the minimum dose of Sugammadex you may have to give actually? We'll come to that dosing later, but thinking about the molecular weight, because molecular weight of Sugammadex is 4 times heavier than rocuronium. So 1 milligram of rocuronium is equal to 4 milligrams of Sugammadex, molecular weight size. So you have to give 4 times the dose of rocuronium. You
Okay.
understood? Minimum dose you require is at least 4 times the dose, so that you are exactly giving the same number of molecules. By giving 4 times the dose of rocuronium, as far as the weight is concerned, because Sugammadex is 4 times heavier than rocuronium, isn't it? 1 milligram of rocuronium, if you say 1 molecule of rocuronium, suppose I say 1 milligram, just like that. So that will be equal to 1 molecule of Sugammadex, which has to be 4 milligrams. You understood, isn't it? So now you have to give 4 times the dose of Sugammadex for rocuronium, minimal. If you just think now I have given rocuronium, now I have to reverse. So same number of molecules you have to give of Sugammadex, so that 1-to-1 binding occurs and reversal can occur, isn't it? So minimum dose is that much. Suppose I'm using 1.2 milligram per kg body weight of rocuronium. So how much of minimal dose of Sugammadex that is required?
4 to 5.
5.
Isn't it?
4 to 5.
Roughly 4.8 milligrams. But usually we give 16 milligrams, 4 times that, so that we don't want to take any chance. We don't want to take any chance. You may be asked, why do you want to give 16 milligrams per kg body weight of sugammadex in order to reverse 1.2 milligram per kg body weight of rocuronium when you have just given it for rapid sequence induction and you are not able to intubate, you want to reverse. So that is the dose. Actually, even 5 milligrams per kg body weight of rocuronium may be sufficient, but it will take slightly more time. But you want it to be reversed very rapidly within 2 minutes or 3 minutes. That is how you may have to give, at least 3 times or 4 times the number of molecules of sugammadex. I hope you have understood. Okay, we will stop at this. We'll just continue for another, maybe about 15-20 minutes will be required for sugammadex. Tomorrow, we'll just continue with sugammadex and then we'll go to opioids tomorrow. Okay. Now, Mona, you are telling that at the end I'll ask about doubts. Now, anybody has got any doubts regarding today's discussion? You have understood whatever we discussed. I think, if you just go and read, you will understand better because, even when I was a student, this neuromuscular junction was really very tough for me. Understanding the anatomy, physiology, pharmacology, reversal, all these was very difficult to understand for me. So the same thing with every student. It is very difficult to understand, but now that is the reason I wanted to make it more simple way of, making you people understand. So if you just, go and read now, you will understand the whole thing much better. So if you have any doubts, you can always, ask me tomorrow, first for a few minutes, and then we will finish off sugammadex tomorrow. Read and come about sugammadex again. You're answering better with sugammadex. So we'll discuss more about sugammadex. And then we will start discussing about opioids. Okay, tomorrow. Okay.
Thank you, sir.
Yeah, thank you. Thank you. Okay. Anybody else has got any doubts? They can, I'm not finding any chat box also being used. Your HOD keeps telling me, sir, let them ask questions. And I don't know why you people are not asking any questions at all. And it is me who has to ask questions. It should not be like that. It should be interactive sessions. So that will be more, attractive. So interactions from you. You are also thinking. You are also thinking why, and why not. And so you can keep asking some questions. So that will make more interesting. Anyway, tomorrow you can ask me some questions in the beginning and then we will go ahead with our discussion on sugammadex. And is there any other reversal agent that has been introduced recently, not introduced commercially yet?
Last.
What about calabedion? You heard about calabedion? You read and come about calabedion also. Calabedion 2. Now, not calabedion 1, 2 is much better. And what about L-cysteine? So these also will just discuss briefly tomorrow. So read and come. Okay. Okay then. Good night.
Thank you, sir.
Night.